Radiology is now the largest contributor of radiation to the population. It's greater than nuclear energy, it's greater than background radiation. And vast numbers of humans are exposed to radiation in CT and dental x-rays, angiograms, both the recipients being the patient and the professionals doing the procedures. And as an interventional neuroradiologist, I was concerned about this because for the last 30 years, I've been doing procedures under x-ray guidance. And I wanted to find a way of doing something about this. So about 12 years ago, I was concerned, and I came home from work, and my mother-in-law, who I love dearly, had just come home from Princess Margaret Hospital with a list of medications not to take prior to her radiation therapy. And it turned out that they were all antioxidants. So that made me think that we could use antioxidants as a method of decreasing X-ray exposure, DNA damage related X-ray exposure in patients and people like me who do image-guided therapy. And it began a research project which has gone on and thankfully has worked. You know the numbers, they're enormous. 80 million CT exams per year in the US, 40 million mammograms, 20 million nuclear medicine studies, 4 billion dental x-rays, 4 billion globally. Most of these, 70% are elective, about 30% are acute or emergent. And the age that the recipient is at when they get the x-rays is the important thing. If a 7-year-old gets a cone beam CT of their teeth, that's far more important than if I get more radiation doing a procedure, because that 7-year-old is going to live 80 years and could then develop, because of the mutations those DNA breaks cause from the radiation, they could develop parotid or eye or thyroid or breast cancer as a result. Every 3 millisieverts is associated with a 10% increase in cancer risk. There's evidence that if you have a multi-detector CT, your peripheral mononuclear cells have DNA breaks in them. And so this is measured with gamma H2AX. So your breaks go up after a simple CT. Your breaks go up after a catheter angiogram. Your breaks go up after X-ray dye and a CT more than a CT alone. If you're on chemotherapy, or if you're getting a nuclear medicine study and you get radioiodine, your breaks go up. If you're on chemotherapy and have a CT and get X-ray dye, they go up more than if you get a CT or a CT and X-ray dye alone, because the chemotherapy impairs repair. So that's all well known and studied. And we also know that there are more and more people having long angio procedures, DAVF embolizations, EVAR, aortic stenting, massive doses, up to 5 gray. And here's a paper in the literature recently from one center recording over 100 patients with more than 5 gray of exposure. That's therapeutic range. In this paper from Canada, from the Canadian Medical Association journal, there was a 3% increase risk of cancer for every 10 millisieverts of radiation in an age and sex-adjusted population of patients, 82,800 of them who had undergone cardiac intervention for MI. MRI causes DNA breaks also, and it's at higher field strengths, higher slew rates, more dynamic imaging that you get these. The FAA have demonstrated that flight crews get DNA damage. Flight crews get the same kind of range of DNA damage and X-ray exposure, radiation exposure from solar radiation that we get as interventional radiologists. I was just chatting to a pilot last weekend. He was sitting beside me on the plane last Friday. They wear sunscreen in the cockpit because of the sunburn they get from solar radiation while flying. That means they're also getting irradiated. So cancer risks, most importantly, cardiovascular risks from low-dose radiation, from the chronic inflammation, from the increase in the active oxygen species. The IAEA pays very little attention to this. They think we wear our badges, and they don't seem to realize we get up to a gray radiation on average. The founders of radiology, unfortunately, a lot of them died from X-ray exposure, from standing in the field when they took their chest x-rays or did their barium studies. Many of them lost ears and eyes and fingers from radiation exposure. Now, we wear our lead, but our heads, our arms, our legs get exposed in the field of radiation from scatter. And here's an image of some of my colleagues with no hair on the outside of their left legs. We took this for fun. That's the side nearest the X-ray tube. Often we feel the heat of the X-ray tube beside our leg. Vito Pereira and Carl Loveblad in Geneva put DLDs all over themselves as they were doing procedures and showed that the left side of the head gets 6 times more radiation than the right side of the head. I wrote a very boring paper on radiation-induced cataractogenesis or cataract formation in interventional radiologists, showing that these are posterior chamber cataracts in the sort of the neogenic layer, where the lens is repaired from or grows from. That's where the cataracts grow from. 38% of interventional cardiologists have posterior chamber cataracts, much, much higher than the normal population who get them in the middle and anterior chamber. So a different type, different location, more common. The dose of radiation that's allowable has been decreased to the eye to 1/7 of the previous allowable dose. In Japan, there are reports of left-sided brain tumors in interventional cardiologists, and we've seen that here in this hospital. So in a case cohort study identifying 31 interventional cardiologists with brain cancer, 85% had left-sided tumors, 17 were glioblastomas, 2 were astrocytomas, 5 were meningiomas. One thing to think about is, should we be screened for mutations that increase our risk of cancer induced by our profession before we begin our profession? Should our fellows be screened to see if they have mutations that impair their ability to repair DNA damage from X-ray exposure? We don't do that. We should do that. Makes sense. Bijan Madari, a wonderful colleague in King's College London, has published in Circulation that different individuals have different sensitivities to radiation, and the same dose given to different people can have more damage or less damage. And in his vascular surgeons, they found that leg protection was helpful. In the dental world, 1.6 billion dental x-rays per year in the US, 4 billion globally. This is a huge number of x-rays. Add to that this issue of mutations and the young age of the patients getting these x-rays for their braces, this makes me worry, and those children should be pre-medicated with something. There's abundant literature showing that radiology technologists have elevated risks of squamous cell cancer, myocardial infarct, all cancer mortality, breast cancer from their occupations, and that's from the NIH. There are other papers from other countries showing elevated risk of leukemia and thyroid cancer in radiology technologists. There's a global issue with a need for stockpiling. You know, we're in the midst of this horrible Ukrainian war at the moment. Who knows what's going to happen with Zaporizhia or supposedly tactical nuclear weapons. They're still more powerful than anything dropped in Hiroshima or Nagasaki, that we seem to make them more sanitized by saying they're tactical. What will happen to that radiation? Or if it escalates in Taiwan, in Korea, in Iran, and Israel, or between Russia and the United States and Europe, what will happen then? We need to have something more than iodine. Iodine only protects you if you live longer than if you live long enough to grow a thyroid cancer, right? But you're still going to be dead of the acute radiation up front. So there's a need to stockpile, and that's where we need to look at what can be done to improve outcomes. First responders who go to nuclear disasters need protection too, and soldiers who are exposed to radiation in submarines and missile silos have elevated risks of cancer. There are papers showing non-Hodgkin's lymphoma is more common in soldiers who work in missile silos in Montana, a 7-fold increase in incidence. There's a lot of data published peer-reviewed excellent quality data showing that physicians or techs, nurses with mutations have higher incidences of cancer and heart attacks than people who don't when they're exposed to radiation. We think our lead protects us. I did a fun study with my students. We checked our lead aprons to see if there was free lead on the surface of the aprons, and it turns out that there was. 61% of the lead aprons at University Health Network Toronto have lead powder on their surface. There are 5 papers on this. We've published ours, including the other literature, as a sort of a review paper in the Journal of Vascular Interventional Radiologist in May last month. And one of the key things was that in the scalp hair of X-ray technologists, there were measurable levels of lead. So they had ingested the dust and it was present in their hair. So what have we done about this? Well, after that discovery that my mother-in-law was going to be more resistant to radiation by taking antioxidants, I looked into this and developed a formulation that blocks DNA damage. What is the mechanism? Everything boils down to the mechanism. So X-rays hit a cell, they collide with water molecules, they break the water molecule into free radicals. Those free radicals bind with DNA strands and then attract oxygen to that break, causing an oxidative injury. Antioxidants bind the free radicals, preventing that from happening. We can measure these breaks by measuring the apparatus and its activation that repairs the breaks. There are 2 principal systems, P53, called the guardian of the genome, and gamma H2AX. And they can be imaged and quantitated with immunofluorescence or immunohistochemistry. And we've developed a lab here at UHN, Toronto General Hospital, Princess Margaret, and at McMaster with Mark Ternopolsky to do those measurements and do those tests. And this is not easy to do. So when I had that conversation with my mother-in-law, my son Ronan and I and our dog Cora went for a walk, and we bumped into another dog. And the owner of that other dog turned out, after chatting, to make antioxidants. So we used his formulation and we did our initial experiments, and Joe Barfoot, Dave Nicholas, and I did experiments drawing our blood, radiating it, taking antioxidants, drawing our blood, radiating it. And we were able to show a substantial decrease in gamma H2AX if we pre-medicated ourselves. In other words, we had less breaks if we pre-medicated ourselves, which is really important. We developed an excellent antioxidant formulation and performed a prospective randomized study, which we published in 2017 in JVIR. Here, this sound like I'm dictating. This is a study that we did in people having bone scans. 5 people had a nuclear medicine bone scan without pre-medication. We see their baseline level of breaks in blue, and then the H2AX activation in red after the radiation exposure. It goes way up. The next group had pre-medication, and there was no statistical difference between their baseline level of breaks and their post-exposure level of breaks once they were pre-medicated. So this was huge validation of what we were doing. Our work has been reproduced by other people. That's really important. It's not just us saying this, but others say this. We then perfected our formulation to extend the protection from not just the nucleus, but just to the mitochondria by adding xanthan and astaxanthin. I find these things hard to pronounce, and selenium and B12. And we did a series of experiments on these elements, creating this complex formulation that now lasts 12 hours. Again, I did experiments on myself up to 1 gray. Here we see basically in blue, no pre-medication, use of a cell irradiator, and then a yellow or orange with pre-medication in the region of 50% protection with gamma H2AX. We did a series of experiments funded by MITAX at Dalhousie University with Vasantha Rupasingham and Graham Dallaire and Dr. Merlin. Vasantha is one of the key people in this whole project 3 of the 4 patents we have are his. And we use a key element of his work, quercetin, which is an apple flavonoid. It's the thing that stops apples going brown until you bite into them. So initially we used carcinogenic irritants against human bronchial epithelial cells. And we're able to show that looking at P53 and H2AX and other measurements of DNA damage, that we could make bronchial cells that had been pre-medicated with our formulation more resistant to damage from NNK acetate, a known carcinogen. And we can measure this increase in resistance or protection of the cell from NNK acetate and indeed methotrexate with gamma H2AX. And we wrote a very boring paper about this. We then went on to use a cell irradiator, irradiating human bronchial cells, and again showed that our formulation was able to protect cells up to 4 gray, which is a huge dose. And we could demonstrate this by using gamma H2AX, looking for double-stranded DNA breaks, and then doing COMET assay for single-stranded DNA breaks. With Mark Ternopolsky at McMaster, I then studied mitochondria. Now, mitochondria are 13 times more sensitive to radiation than nuclear DNA. Their inheritance is purely maternal. It's really cool. And we studied this in mice. Once you initiate damage in the mitochondria, it becomes a self-fulfilling series of cyclical further damage. So we took black mice, 16 weeks old, with a control group, with a group that got radiated, and we've got a group that were fed DNA halo or our formulation in Nutella. They love Nutella. And then we harvested the organs. We were able to demonstrate that we had a profound impact on protecting mitochondria from DNA damage when animals were pre-medicated. We published more papers. We have 9 in total now showing this work. We've been able to show that we can protect cells against epileptic activity in brain organoids in a mouse and human model, and increase resistance to seizure activity. And that's really important. Finally, we did our ultimate study, which is a prospective randomized 3-arm study, blinded study in 33 people. Each of the physicians involved, and there were 20, signed up to 6 blood draws of 20 cc's. The tissue or blood was analyzed in 2 separate laboratories, one at McMaster, one at UHN, disconnected from each other, blinded to what each other was doing. There were 3 different weeks of work here in the interventional radiologists. Week 1, on Monday and Friday, we drew their blood. They just had a regular work week, and we measured their breaks. Week 2, before a big procedure, the 20 people were divided into 2 groups of 10. One group got no pre-medication, the other group got pre-medicated, and we measured their breaks after the procedure. And then week 3, on Monday and Friday, blood was drawn, and folks got to take DNA halo every day, see if we could load them, make them more resistant. And basically what we showed was that we were able to have a marked impact, a positive impact in protecting mitochondria and nuclear DNA. We were able to decrease activation of repair apparatuses in the nuclear DNA by 78%, and we were able to decrease the activation of mitochondrial repair apparatuses by 54%. Okay, so very impressive results. The mitochondrial work has never been shown before. And the nuclear work has only really been shown by us and that other group that reproduced our data. We looked at the week 1, day 5 breaks and compared them to week 3, day 5 breaks. In other words, after a week of DNA halo. And we were able to demonstrate with gamma H2AX that we had about a 50% decrease in H2X breaks between the baseline week 1, day 5, and week 3, day 5. So again, it works. And in some individuals, the protection was much greater than we anticipated. On the left is one individual's breaks on a Friday evening after no pre-medication and a week of work versus a week of pre-medication. So significant impact. We're going to go on and do more work. We're going to radiate those specimens to 1 gray, all of them. We're going to look at how the age and experience of the interventionalists affects their mitochondrial repair. How revved up is the repair apparatus? And we're going to look for mutations in their nuclear and mitochondrial DNA and see if the more experienced interventionalists after 10, 20, 30 years of radiation have more mutations than the young fellows. We're going to submit this work to a high-impact journal, a very high-impact journal. And we're beginning to work on that paper right now. You know, there are conversations right now that are important with people in the military and intelligence world about shipping DNA halo, our formulation, to Zaporizhia to protect the young men and women, or men and women fighting around that power plant or who are at risk of being attacked with nuclear weapons. The stockpiling issue is disturbing, but it's a place we may have a role, and we're working on our shelf life to get to 5 years. Our accelerated testing already shows we're good to over 3 years at the moment. I just want to thank the folks at the Petermont Cardiac Center Innovation Committee for supporting this work, for my friends at Cora Therapeutics, the company we set up to make these pills, for Santharupa Singham, a great partner and inventor, Mark Tanopolsky, a fabulous collaborator, Peter Carlin, who works here in the neurology group and is an epilepsy expert, with whom we're showing that DNA halo can decrease mitochondrial abnormalities in people with epilepsy and increase resistance to seizure activity. To Dave Miklas and Joe Barfoot, with whom I started this work many, many years ago. And to Cora, our dog. Thank you.